Hi, my name is Nancy Joyner. I'm a palliative care clinical nurse specialist, and I'm here with the opportunity to talk to you today about what matters most, one of the four M's from the age friendly uh, perspective on health systems taking care of our elders. So, my topic today, as I said, are what matters most, and I'm representing both the Center for Rural Health for UND and Honoring Choices North Dakota. I have three objectives that I'm hoping that we will have today: how to align medical care with the people that we take care of from their perspective as far as outcome goals and wishes, and some of the tools that can be used to screen for each person that we take care of, because it has to be individualized. Then we'll talk about and summarize some of the action steps that you need to do to implement into your own practice on how to include what matters most. We know that for what matters most, for older adults, it's very much into their independence, their sense of control, not being a burden. Those are the things that really matter. And we need to touch bases on that. What are values? What are goals? What are wishes with wherever they are with their perspective? From a health systems perspective, really takes into the effect of making sure that people are being heard, that the utilization is being appropriately managed, and that we're not having it used when people do not want it. So there are some non-beneficial and other treatments that are being done. Almost 30% of what we do is not needed, not unnecessary, not wanted, not beneficial. But for everyone, let's get on the same page. You know that we need to have that sense of community, that we do understand one another, and we're talking the same language. And so, again, we have our healthcare language, and we need to get down to what really matters to people. With our world of COVID right now, serious illness can be at all ages, and we know that it really impacts our older adults, and we need to take care of them and be prepared to do the things that they need. The clinical picture, as we know, can worsen quite quickly, and they're not prepared for that, especially if they have underlying comorbidities and other conditions that are there. We also have restrictions with no visitors, so they're being abandoned from their family, the connectedness that they need, the whole sense of community is not there. We also are missing out things like glasses and hearing aids. Do they have their phone, cell phone and charger? Do they have connection methods for communication that needs to be there? And often the frontline providers are not getting the information they need because the person's not able to share that because it's come in so quickly, and to be able to reach out to the other family and who's involved with that. Really want to talk about things that are important. What are patient priorities? They're not always the same for us. We might have our own agenda, but it's important for us to really look at that, to really understand what it is. And values, what does it really mean to have values? What are their specific goals? What are their abilities and activities that they're able to do? Are they living well? If we look at the whole big picture of that with where they are there limits or trade-offs that we have to be looking at? The uncertainties, what things are unacceptable, fears and worries that may come up from there, experiences, what they've had with serious illness in the past or with other people, and definitely sources of strength, such as spirituality, family, community, etc. So it's important that we listen to their emotions, we listen to their values, and put that in perspective when we're designing our care plan, not specifically just for the disease. The other thing is outcome goals. When we think of outcome goals right away, we think of specifically perspective from a disease, but we as are human beings with many perspectives, and we have to put that together, with where we are with the sense of who they are in the belonging world. And when we talk about preferences, we use the word care preferences, but everybody should be provided care. It's more the treatment, the physical goals that we are looking at. But if you don't ask, you won't know. It becomes the elephant in the room. We often forget that who's going to start the conversations and how do we start the conversations? Is it comfortable? Are we allowing them enough time? Are we doing more of the talking, or are we allowing the person to do the talking for that? So the social determinants of health are things that we need to be thinking about. Are they, do they have enough food? Are they having enough communication going on? Are they having the community that they want and working from that? Are they still working? Are they having other environmental things that are going on? Definitely cultural. And cultural doesn't just mean ethnicity. We're talking gender, where they live, who is their sense of community, their spiritual components, all of that that goes along with it. And then the ultimate goal, though, is that sense of belonging and the interconnectedness that we often miss in the healthcare world because we're so specifically designed for treating a disease. When we elicit values, you say things like, I want to find out what matters most, connecting with others, enjoying life. What does a good day look like for you? Maintaining health and functioning the best that they can. So, focusing on really what matters. And again, what matters to you and me may not be the same as what matters to somebody else. Just even what we offer treatment, is it helpful? Is it bothersome? Are these things doing the things that you are expecting? It may be, a journey, the whole trajectory on people getting better or getting worse over a period of time. Or is it unwanted care that they really didn't want in the first place? Do they have the opportunity to say yes or no for medications and treatments with how far and how much they wanted to go? Really, when we want to go forward, then is to clarify those outcome goals. What are those things that we'd be willing to do and able to do if you had more energy? If we really were going to be able to get back that, and then to really target it and hone in on one specific one. What is the one thing more than anything else that is the goal? And sometimes, people think health, sometimes it's to do with families, sometimes it's to allow natural death. So there are all different kinds of components of where somebody is in any given time. We have things called conversation starters, and this came from patient priorities care that you can find. It's who are the important people in your life? What about your health? Are you hoping your health care can do more for you? What's important from that perspective? Then it's from what kind of actions do you want to take? What are your activities? What about dignity and self sufficiency and all these different components that fit together? So when it comes to mind, what matters most in these different areas? And it's surprising the things that are there. Do we allow enough time to really process this and hear what somebody has to say? We have something called a Go Wish game. It's one of my favorite icebreakers. And the example I'm going to use, there's an online version that you can use now in this day of virtual. But I did it with a 4-generation family. I had a 9-year-old. It's designed for teens and older. But I had the 9-year-old, her mother, grandmother, and then the great grandmother that I was taking care of. You have a deck of 6 cards, including one that says, a wild card for something that might be important. But it goes through things like those last screens that we talked about, what matters most as far as free of pain, being hooked to machines, time with my family, trusting my doctor, etc. And you prioritize them. You take the top 10 and put that in your top pile, and then the others in the other. Then, after you've chosen those 10, you talk about them with one another. I really like the hard games, with the actual cards that you can play with versus doing it online, because sometimes as you discuss it, that's the important part more than putting it into an alignment is what does this card, this meaning trigger for you to make a decision and going from there. The other one that I really, really like is the Serious Illness Conversation Guide. It's from Ariadne Labs. For those of you that might be familiar with Atul Gawande, who is now going to be on Biden team. I'm very excited about that. But he goes through, the guide first, to set up things, thinking in advance, finding out, is this okay for them? What is their understanding of now where you are with your illness? How much information, not what information, but how much? Because some people want just this little bit. We're here again. Remember how we get there. Giving that prognosis, tailored for that information that's there. If that, again, within the perspective of the whole team being on the same page with that. The goals, if your health situation worsens, what are your most important goals? What matters most? And then fears and worries. What is the biggest fear and worry you have about your future? The function. What are your abilities so critical to your life that you can't imagine living without them? And then the trade-offs. Is you became sicker, how much are you willing to go through the possibility of gaining more time? Then again, from a family perspective, how much does your family know about your priorities and wishes? And then you can talk about, how much do you want them to know? So you're going to be acting on affirming that commitment to that, maintain some recommendations, and make some to the patient that they may or may not agree with. And I give them a time out for this, and also an opt out, of the things. You don't have to do these things. These are options for you. Make sure to document your conversation and get it to everybody else that needs to be on from the team. And then provide the person with family communication guides, something that they can talk to one another about to going there. So again, this is available on the website for you, and I have it in the resources at the end. Vital Talk is another great one. Makes communication skills for serious illness learnable. So this is scripting type things with how to do that. There's actually on your phone now, you can actually, I have it downloaded, that an app called Vital Talk Tips, and it goes through each different section, whatever different information that you want, from advanced directives, some of the online things, what about if a person's getting close to nearing the end of life, etc. So there's lots of good information there for you. Things that are very important too are, what are people able to do? Their basic ADLs. Are they able to do it from a perspective? Do they need some assistance with it? Most individuals want to maintain independence or regain it as quickly as possible, and not to be a burden or not to have too much reliance on somebody else. Think of your own self. How would you feel about somebody taking you to the bathroom and helping you wipe your backside, or a granddaughter or something of that nature. So these things, again, with boundary type things, and that self-reliance is such an important thing. Then we add what we call the instrumental ADLs, with groceries and being able to pay bills and go shopping and cooking, and just maintaining your daily life, with the things within your home, managing your own medications. Are you able to do all of that? So again, these things that do matter to somebody. Some of these things, this is behind the burner, but it's the top thing burning on their list of questions, and what can we do for it? Through the Canadian Occupational Therapy, they have what's called a What Matters screen. And these are all the different how important is it to you to do these different things? Again, these are available for you in the resources to help you to ask questions. We often recommend, utilizing other people if you need to. When we get to this, they say, based on these activities, how would you rate yourself? It is important to me, important but I like or need some help with it, not important, I'm able to do it on my own, or could use some assistance. It really gives some perspective on where a person is at any given time. And of course, baseline changes over a period of time as well. There are some tips on how to act on it once you do have this. To use this as a care guide decisions, that it guides you to what you're going to be doing. It's going to aid in that communication that's there, because it's going to be shared decision making. So often when I'm in a family meeting, they'll say things like, I don't know what I don't know. How can I ask questions if I don't know? So it needs to be dialogue going back and forth, clarifying goals and making sure that people do not feel lost or confused along the way. And then to assessing, really, is this beneficial or not? What may be beneficial to you and me may not be beneficial to somebody else, and vice versa. So it's important to have those things out in the open and discuss it openly with them. We want to be able to collaborate in negotiations when they differ. For instance, I can offer you a CPAP. I know you don't like it, but can we give it some time, do a time-limited trial to see if it does show some improvement or makes you feel any better? Many people are just really reluctant to try new things, and so time-limited trials are always great with a goal at the end. And make sure to include your interdisciplinary team, social workers and nurses, nurse practitioners, the chaplains, therapists. It's amazing, all the different things. Psychologists, oh my gosh, we use psychologists quite frequently, with that, so that we have that communication going on. We all have pieces of the puzzle that we can put together, because we as humans are more than just a physical body with a disease. It's a person with cancer. It's not the cancer patient or the dialysis patient. It's the person experiencing that disease. The biggest thing is pull in palliative care. Almost every hospital now has some dimension of palliative care. If you're not familiar with it, check it out, because they offer so many different things that are there. and most important is the ability to have time for more communication, time for addressing symptom and issues needs, time to really explore what does matter. Because there's so many broken pieces, we all have this time frame. By pulling them in as yet another team member, it's just an amazing, amazing thing. So please don't forget palliative care. When we're looking at some of the decisions, then use those patient priorities as the focus of communication to make healthcare decisions. We have, our list of different orders that we can do, different medications and different testing, etc. But use that to filter back to what it is we really want. Do trials, little bits here and there, especially if there's any kind of complex or uncertainty of something going on. Because a time-limited trial will say, yes, it will not work, or no, it won't. I've had people say, I'll try dialysis for my family, and some people say, no way, Jose, and some people say, this is a piece of cake. Other people experience death because it did not work. And then align the care and decisions among the patients and clinicians that you're taking care of. That it's going to be guided by their priorities. So make sure that those decisions, that we're all on the same page, that we really have that strategy to go through with that. We start, again, the essential ingredients is to ask what matters, who, what, when, what kind of questions, open-ended questions. They should be talking, the people we're taking care of should be talking a lot more than we are. And then to document what matters, with those different things that are there. This goes back to that patient priorities care that I showed you earlier. Then you're going to align it with the plan of what it is. How do we know if that has happened? Have we tried that in the past? What has worked in the past? Can we align it with things that we can do moving forward? So we have the past and the present to work with, but we need to look for the future as well. So that leads us to what is advanced care planning. So many people think immediately of the advanced directive, which it's much more than that. It's the process and communication that needs to occur. So the definition is truly a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding current or future medical care. The goal of advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious illness and chronic illness. And, we often miss that one part of it. So this leads us to what is advanced care planning? What is the future? Because it's more than just that piece of paper in the advanced directive. The definition is advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values. It's the communication part, what their life goals are and preferences regarding current or future medical care, with the goal of ensuring that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. So if we don't ask, we won't know. And we need to include that, and we don't always incorporate that into what we're doing. Advanced care planning is a whole person approach. We need to, and sometimes it's going to be other pieces of this pie that are going to be, they're not always exactly the same amount of size, that are more pertinent in coming forward. It's not always just the physical part, but it's important to be looking at it from a full perspective. And it's across the whole lifespan, the whole continuum, from the time when we're healthy and independent to when we're developing more chronic or disease or advanced illness, to the point of nearing the end of life and allowing natural death. The goal always is to maintain and maximize health and independence wherever it is. So why is it important? It improves patient satisfaction with care. It improves the quality of life for people. We have less unwanted medical care that aligns with wishes. So if you don't have the communication, we're not going to be able to do that. And the big one then is it puts less stress on the person that has to make decisions when it's the most difficult. For the surrogate, for the healthcare agent, for the backup person when their person is incapacitated and unable to speak for themselves. It's not easy. From a perspective, individuals and families don't want to talk about death. We're a death-defying, death-denying society. And it's important that having these conversations to identify these things. So many people, from a perspective of an individual, don't see the importance of it. And our lack of awareness during this time of COVID has been come to the forefront more than ever, so that the understanding becomes more significant, that the condition can change at any given time. Often there are unclear treatment options and decisions, and we need to pull that to the forefront as well. We also don't want to have to deal with it, but often there's family conflict. One family member may say to another family member, I don't agree with this. Or they might be arguing right in front of the person, not recognizing it's from the person's perspective that we want to do it. And a big one is that they don't designate a healthcare agent. By default, our standard of care is we do everything. By default, we follow our century code with next of kin of who it is that we will be talking to that may not be on the same page. And so the earlier we have this conversation, the better it is. The who's and the what's of what we need to do. With the whole delivery of patient-centered care, which we really, really want to focus on, it's not just disease and from a perspective of a healthcare provider anymore. That we have multiple transitions that happen. So there are times that we don't need to be having people come in the hospital. Even during COVID, there are times, but what are their options? What are the things that are out there? So that last bullet with, we're not getting palliative care out there sooner. It's delayed. And so we have to have that access sooner. There becomes more demand for the family to take care of these people, managing the households, all the other different things, which becomes a burden. And these are things that can be avoidable, which is very nice. So the Institute for Healthcare Improvement says there are key steps that we need to do. Find out what's going on, check their history, conduct the 4M screening, with the different things we're talking about. And today my focus is specifically on what matters. And then what are some daily prevention and maintenance managements that we can do? What if it changes the condition? What are we going to do? Plan A, Plan B, etc. for that. And then to work from there. The same type of thing would be from a hospital perspective that you would do in primary care, that you would co-create, a goal-oriented care aligned with what matters. So again, really focusing back to the person's priorities, not just from a medical perspective on disease. Asking, what do you want me to focus on while you're with me and under our healthcare team? Focus on what matters to them, not here's what I'm going to do. Because so many people will say, well, do everything, or we don't know what we don't know. So that's why we have to go back to the whole perspective of goals and wishes, what matters. And if you have somebody that's advanced or serious and is considered, what are your most important goals if your health situation were to worsen? Planting that seed that things may change instead of letting them, there's a different perspective of hope that will come up, but instead of kind of stringing them along that everything's going to be back to normal, because that's not a good way to go either. One of the things we have is what's called POLST, which is used to stand for Physician's Order for Life-Sustaining Treatment, but it now just stands for a Portable Voluntary Medical Order. It's very nice because it's signed by the patient or their agent if they're not able to sign for themselves, and put into order by a physician or advanced practice provider. But it is portable from one sitting to another. The philosophy nationally is that individuals have the right to make their own healthcare decisions, that the rights should be based on decisions about life-sustaining treatment, describing these things, and receiving comfort along the way. Comfort should always be provided as care, and I mentioned earlier about care and treatment and interchanging those words, because comfort care does not mean do not treat or do not resuscitate or any of those type of things. Care should be, all of us want to be kept comfortable no matter where we are. It's very, very important for what it is. We have on our, what we call our Honoring Choices North Dakota has a North Dakota POLST, and this is our North Dakota POLST form. There's a whole conversation and documentation guide so that it will help the person understand on where it is and what we have. It separates out CPR from any other kind of medical treatment. So that resuscitation, do we allow natural death or do we attempt? Because we can't guarantee it. And it's totally separate from how much aggressive medical treatment somebody wants, from just focusing on comfort measures only to limited or full treatment. Then there's a section on nutrition as far as how far and how much somebody would want. The documentation part includes where we are with who we talked to or what did we refer to, and then we have them sign it along with the attestation from the patient. On the second page, then we have who was the healthcare agent that prepared the form, because it doesn't necessarily just have to be the person that is putting it into order. Just the same as somebody is doing an informed consent for surgery, somebody else may have discussed it for them, or other treatment options that someone else may have had the discussion with them. But this is a double check, since it's a life and death, before somebody signs this, that these things are in place. The directions for it are on the back as well. We have a whole CME available on our website for more education and scripting and how to talk about this more. But I do encourage you to be looking into utilizing PULSE for those people that are seriously ill or nearing the end of life, the last 1 to 2 years of somebody's life. And they do complement each other. I forgot to mention that too. An advanced care directive and those conversations should complement one another, but they're used in different aspects as well too. We do also, though, want to provide information for the families, with how to have further conversations. It doesn't stop here. It should be lifelong, actually. It should be beginning from the time of somebody who's only 18 years old and moving forward from there. And you want to engage the whole team, the nurses and social workers and chaplains with this conversation. So we can do little bits and pieces before we have it complete, and it may change and transition over time depending on healthcare conditions, etc. There are staff that are trained specifically with having facilitated conversations, and I would encourage using those. We have in our state called Honoring Choices North Dakota. It's a collaborative throughout all the different agencies, disciplines, institutions, throughout the entire state, with how to have these goals towards having advanced care planning conversations and honoring people's wishes, thus honoring choices. The next few slides I'm going to show you are some other objects we have. We have the Stanford Letter Project and Bucket List. That's very nice. The Prepare for Your Care, the Conversation Project, and then the Post Overview as well. So this is our Honoring Choices North Dakota website. If you type in Honoring Choices ND, you'll probably find us. We have a section specifically regarding like healthcare directives and resources that are there, some of the upcoming events that we have. We have a specific tab at the top for PULSE, and that's where you can find the CME if you drop down on that one. There's, how to do facilitator training, some healthcare directives, including how to do a notary online, and other resources are there for you. This is the Stanford Letter Project website. This one is a tool that you give to the patients before they see the doctor about what matters, so that you're planting the seed for some of the conversation that may occur. They include the templates for that, as well as the bucket list, if you see that there. So the What Matters letters are very, very valuable for moving forward in that direction. The Prepare, I have several slides on this one, but one of the steps is to decide what matters most in life. So it's not just the who, but the what, and how to tell people about that, questions to ask your doctor. Prepare helps the skills to identify that, how to talk to families and friends, how to make informed decisions, and getting the care that's right for them. That treatment is that missing piece is that conversation. So preparing for them. So it was created with many different people from different age groups. They have actual videos that can model how to have advanced care planning conversations. And so sometimes that visual along with auditory makes a big difference. They talk about how to make a decision about the decision maker and some of those preferences that are there. This one I like too is that they have a medical plan during COVID, a list of your medications, what to bring to the hospital, not to forget. And so many people, when they do have a healthcare directive, put it in the wrong place, like the safety deposit box, where it should be kept with wherever their list of medications are and things that are important. An attorney told me once, think of it as important as other documents, that you might want to keep a copy in your glove compartment book. There's even a My Directives on an app, or you can put it on a jump drive and carry it around for you. So these are things to be considering as well, for a time of that. The next one I wanted to talk about was the Conversation Project. This one has done a really nice job because they have something called starter kits from, the black or white, the gray zone, but you have this whole from doing all to doing nothing, with what it is that people want. And they have it in many different languages, so it's been translated very nicely as well. How to talk to your doctor, what kind of questions we should ask, because remember, medicine is consumer based. It is monetarily based, and so as consumers, we should be able to have choices and have things explained into a way that we are done. Do we need to shop around a little bit more, etc. From that. There's also how to make a decision on your healthcare agent, how to talk to people that lack capacity or have dementia, and then there's a whole section on pediatrics. So they have a really, really broad range on there. This is our post information sheet for families, what it is, why is it important, how do I get one, etc., so that we have something available visually for somebody to have as well. And this is my list of all the different references I talked to with the different websites. I highly recommend you take some time to go over them and get more and more familiar. So I do hope that this has been helpful for you. For any questions, please feel free to reach out to me at nancy.joyner@und.edu or nancy.joyner@honoringchoicesnd.org. I appreciate your time today, and I hope this was helpful. Wishing you the best and taking care of yourself. Have a great day.